Hello, and welcome to the Health Data Ethics Podcast. I'm your host, Jenny Owens, and today we're going to break down the Joint Commission's brand new guidance on the responsible use of AI in healthcare, which was created in collaboration with the Coalition for Health AI. This documentation is really helpful indicator of where Joint Commission's head is at as far as the regulation of AI in healthcare, and it's a kind of a preview of what might soon be required for accreditation. So let's break this down. First of all, I want to talk about the authorship of this guidance. This guidance is a joint effort between the Joint Commission, which is an accrediting body for healthcare organizations. They're doing this in collaboration with the Coalition for Health AI. This is a nonprofit that is really aimed at promoting the responsible use of healthcare artificial intelligence. The guidance builds on the National Institute for Standards and Technology's AI Risk Management Framework, the National Academy of Medicine's AI Code of Conduct, and the bipartisan House Task Force Report on Artificial Intelligence. The overall goal of the document is to help promote a shared understanding of what responsible deployment of artificial intelligence looks like in a healthcare organization, and to help healthcare organizations create an environment where the risks of AI are minimized, mitigated, and managed so that all of the potential of artificial intelligence, all of that transformative potential, can be harnessed. It's really intended to be used as guidance for a healthcare organization when they're thinking about what's important to have in place when they're using artificial intelligence. It's not intended explicitly to direct the development or the validation of AI tools. Joint Commission did say that some of these guidances will be released in subsequent responsible use of AI playbooks. The Joint Commission is also working on a certification program as well. So there's lots more additional material coming on AI in healthcare. As I was reading this document, for those of you who know me personally, you know that I used to work in the lab, and I kept thinking about this parallel with a CLIA inspection. We're looking at validating our tools. We're looking at documentation. We're looking at staff education. We're looking at defined workflows. This feels really very similar to other inspections, other audits that you might do with very specialized knowledge with varying levels of risk for an individual test or an individual AI tool. As we start to get into the guidance, the Joint Commission and CHI called out 7 elements of responsible use of AI in healthcare. One of them is AI policies and governance structures. Number 2 is patient privacy and transparency. Number 3 is data security and data use protections. 4 is ongoing quality monitoring. 5 is voluntary blinded reporting of AI safety-related events. 6 is risk and bias assessment. And 7 is education and training. Let's break down each one of these. So number 1, AI policies and governance structures. No surprise that this is top of the list. Healthcare organizations need to put real structure around how AI gets used. That means having policies, yeah, but also an actual governance team that pulls in folks with varying subject matter expertise, people from clinical areas, IT, legal, compliance. You want the people doing your AI governance who actually understand not only the risks, but also the workflows. And you need in this particular bullet point, the Joint Commission also recommends a clear escalation path to leadership and a clear communication path for when things go well and when things do not. Number 2, patient privacy and transparency. If you're using AI in your hospital, you have to have really clear policies already about how patient data is accessed, used, and protected. AI runs on data. And if your patients and your caregivers don't trust that you're handling that data responsibly, the trust in your overall organization is going to tank. So you need guardrails in place for how that data gets used, for privacy, for transparency, and for patient consent. You want to make sure that you're protecting any data that could identify a patient. This is just regular standard HIPAA, but with a little AI sprinkle on top. And you want to take the opportunity to be upfront with patients and with caregivers when and where it's appropriate. Where is AI being used? When is it being used? How? How is it influencing patient care? And what is their data being used for? In some cases, that means it's transparency. Hey, I just wanted to let you know that we do in fact use artificial intelligence on our inpatient floors. We'll take the time to explain to you what these tools are doing and how they might impact your care. In other cases, you might actually need to get consent. For a great example is an AI scribe, a digital scribe. If you're working in a 2-party state, such as Florida, you might actually need to get a patient's verbal consent to use the tool before you start that process. Number 3, data security and data use protections. This one's for my cybersecurity friends. If you're using artificial intelligence, you're working with big data sets, and that means more surface area for risk. Healthcare organizations already have a responsibility to keep that data safe, not just from external threats, but from misuse inside the system too. So that means that all of your AI vendors, all of your contractors who are doing development, they all need to understand what they can and cannot do with patient data just as well as your employees do. If you're sending data out for model training or for validation, your data use agreements need to spell out exactly what's allowed and what's not. And your security practices overall need to keep up with how AI is actually being used across your system. Bullet point number 4, ongoing quality monitoring. Your AI policies should say something about validation, right? You want to make sure that a tool is going to work for your patient population in your health system before you put it into production. Once that product or model or tool is live, you still have to keep an eye on it. You are obligated to continually do quality monitoring. Data can change, right? You have an Epic upgrade and suddenly your tables have shifted a little bit. Software gets updated. Some tools are designed to continually work on their own. All of that can change how a tool is performing. So you want ongoing risk-based monitoring that matches the tool's impact. If your tool is influencing clinical decisions or treatment directions or, direct patient care, make sure that you're looking at it really often, right? A high degree of scrutiny. If it's doing lighter work, maybe administrative work, if it's helping with documentation, or even if it's a back office tool that's intended to look at, like generating meeting notes, maybe you can review that on a lighter cycle. Also, as part of this bullet point, we need to document who owns that monitoring, what gets checked, and how are you determining what gets checked, and how often? And then who do you escalate to when a tool has really veered from its appropriate path? It's no longer performing the way you thought it was. It may be too risky. Which brings us directly to number 5, voluntary blinded reporting of AI safety-related events. A clear path for escalation of these sort of safety-related events is crucial. If something goes wrong with an AI tool, or even if something almost goes wrong, right? You want a reporting pathway that can capture not only actual events, but also near misses and good catches. You need a way to be able to capture those, to learn from them, and ideally be able to share that information with others, both inside your organization and in the case of, for example, a vendor, you want to be able to share that information back to the vendor as well. Hey, your tool almost harmed our patients. Let's talk about ways we can make this safer. This is exactly like patient safety reporting. It's just got AI flavor on it. So this means that we want a monitoring system and a reporting system that can capture unsafe recommendations, weird outputs that people aren't quite trusting, or any bias that might be creeping in. And this wouldn't be punitive, right? Like most health systems have a retaliation-free way to escalate safety concerns. The goal is to be able to spot patterns and improve the entire system. We may be able to use structures we already have, like incident tracking or safety event reporting. The Joint Commission has a Sentinel event process. The other thing that we want to take into account is if we're working with a tool that is FDA regulated, there are reporting channels at FDA as well that you should take advantage of. Point number 6, risk and bias assessment. So back in bullet point 1, we said we needed AI policies and governance, and a good AI policy and a good AI governance approach will cover bias and risk. In this bullet point, CHI and Joint Commission are making explicit recommendations about establishing processes to document potential risks and biases. They recommend using CHI's applied model card or similar documentation. I love the model card documentation. That's going to gather information from the developers or the vendors on any known risks, biases, and limitations of the AI tool, but it also documents who are the intended end users of the tool. What are the approaches that the tool takes to accomplish its job? What are the workflows that need to be accounted for when you're using the tool? It's important to note here that bias isn't just a data problem, right? Bias can show up not only in training data for a tool, but also like how the tool was built, what things are weighted, how it's deployed, or even how it's used, right? Going back to my canonical example of creating a model that will predict which patients are likely to no-show, but then the action space is also a place to introduce bias. Do you double book the patient? Do you give them a less desirable slot? Do you call them and offer them a ride? Do you send them 30 notifications instead of 20? So even if you get really good information from your developers or your vendors, you still have risk and bias mitigation responsibilities locally. And then once your tools are live, your monitoring process, that's bullet point number 4, should include these ongoing checks for bias creeping in the action space as well as in the model itself. Finally, point number 7 is education and training. I really disagree with placing this one in last place, but I guess somebody has to be last. If you're putting AI into clinical or operational workflows, you have to train your people and your patients. Your workforce needs to know what the tool does. They need to know what it doesn't do, and when they should trust it versus when they should raise their hand and say, hey, actually, I don't think this is working. like bullet point number 5. That means we need role-specific training for the folks who are actually using the tool, and ideally basic AI literacy across the board so that people aren't going to fall prey to algorithmic bias and blindly accept whatever the algorithm spits out. You want a clear path for the staff to or access the tools documentation, that model card that we talked about, and understand your organization's AI policies. That's bullet point number 1. They should know how to flag something weird and unexpected, and they should know who they talk to if the tool isn't working as expected. So this is best practice, but this is also a change management approach, right? If you want your adoption to go well, your people, your caregivers, your clinicians, your nursing staff, your operational folks, they need to feel like partners. The more context you can give them, the better equipped they will be to spot additional risks that you might not have thought of, to catch errors, and to get real value out of the technology. So this guidance is voluntary for now. In the future, I feel like it is very likely to be folded into Joint Commission surveys. Going back to my lab days, just like CLIA doesn't really care if you bought a validated analyzer for a vendor, they want proof that you validated in your lab with your people, with your reagents and your specimens. Joint Commission is going to want to see that you validated and governed AI tools locally and not just accepted vendor claims. So let's be action-oriented about this. What can we do right now? Thing number 1, inventory your AI tools. Most organizations have an idea of what AI is already live in their system, but they may not have a comprehensive inventory. So start by listing them all out and creating an inventory that you can then consult in the event that you need to provide documentation on your AI tools that are already live. Thing number 2, build real AI governance. Use a risk tiering approach. Make sure that you have the appropriate level of scrutiny on higher risk artificial intelligence tools used in diagnosis or treatment decisions. Make sure that you have, going back to your inventory, a documented owner for each tool, and document the validation approach. Know who is in charge of ongoing monitoring and have a clear escalation pathway for if things go off the rails. And then number 3, make sure that your workforce is trained and your protocols are documented. So your workforce needs training just like they would with a new EHR module or an exciting new update to the Microsoft platform. What does this tool do? When should they override it? How do they report unexpected behavior? And then document your protocols. If I would just want to learn about a new tool, where can I go to find these references? How would I know what we already have live in our environment? If I'm being approached by a vendor or if I have an idea for development, how do I know what do I need to go through for validation and what might my tool be in competition with inside our ecosystem? This document is a rich text, and I feel like we are going to be referencing it for the years to come. I'm very grateful to Joint Commission and to the Coalition for Health AI for putting out this guidance because I think it is succinct and very action-oriented for health systems that are interested in using artificial intelligence responsibly. If you've got questions, if you've got stuff you want to discuss about this new guidance, please drop me a comment. I would absolutely love to hear from you.